Oh, wait, maybe not.
Oh, we need.
It's showing recording.
Whoever the host is.
Oh, he might have recorded it.
Oh, it says it's recording. All right,
Yeah.
this is going to be a great start to it.
Okay, Casey, are you ready? All right, EHP, you may begin your introduction.
All right, so imagine one day you're at home and you're doing your everyday tasks. You start the morning out, soaking up the sun in your garden, tending the animals on your farm, keeping up with the duties of your home. Then later in the evening, you go to bed, everything's fine. The next morning you wake up and you feel incredibly weak. As time progresses, it continually gets worse and worse and worse until your only option is to go to the hospital and get that checked out. Your life has suddenly changed just like that. You don't know if you're going to get better or if you're going to get worse. This is all a new thing. This was a reality for Grace, who's a 52-year-old Native American woman living on a Navajo reservation. With the diagnosis of Guillain-Barré, it didn't look good. There was a lot of uncertainty. She didn't know if she was going to get better or if she was going to get worse. However, an experienced occupational therapist would know of one particular model to assist in guiding her treatment. The occupational therapy model, EHP, or also known as the ecology of human performance, is a model that can be directly applied to this woman's life by pulling from known intervention plans set in EHP, which are developed on first-hand observation. EHP focuses on the person, context, task, and performance. And then this guides us in translating and creating them into practical interventions. So as you can see, we have all areas of this model covered in this case.
Okay. Model B, you may begin your rebuttal.
While the EHP model is a great model, we do not believe that this model is the best model to apply to Grace's case. Grace exhibited full body paralysis, and while she is able to move both arms slightly, both legs remain paralyzed, and she is experiencing continued paralysis of her trunk muscles. Now imagine working with an occupational therapist who does not focus on rehabilitation, which would be crucial in order to regain gross motor control skills. That would be the result of using the EHP model.
All right, Model B, you may begin your introduction.
And now I will set the stage again. Imagine waking up one day and experiencing severe weakness and respiratory distress, only then to be airlifted from your home to a hospital that is located 4 hours away. The diagnosis is Guillain-Barré syndrome, which has manifested in full body paralysis. For Grace to be diagnosed with GB leaves her with many impairments and changes in their occupations. The Canadian model of occupational performance and engagement, the model we are advocating for today, focuses not only on occupational performance, but also on occupational engagement. This engagement feature is a valuable concept for Grace's intervention process because it highlights the fact that one can still be engaged in meaningful and valued occupations without actually physically performing the occupation itself. Grace is a 52-year-old Navajo woman who, before her diagnosis, was an independent and resourceful individual. A very unique component of the CMOPE is spirituality, which is centered at the core of the person. From what we know about Grace, her identity has a strong influence from her spirituality. She is surrounded by her Navajo culture and lives on the Navajo reservation. Her culture is a huge part of who she is and how she chooses to live, and ultimately plays a large part into why the CMOPE would be the most suitable model to use in therapy intervention. Another benefit of the CMOPE is that two other models, the Canadian Practice Process Framework and the Canadian Model of Client-Centered Enablement, are embedded into the intervention process. Together, these models give a comprehensive view into the relation of the person, environment, and occupations. as well as the context and that facilitate change in outcomes directly influenced by the wants, needs, and capabilities of Grace.
Model A, you may start your rebuttal.
So the CMOPE in your opening statement values cultural surroundings and spirituality. One of my concerns about your model is that it makes assumptions that is based on a Western-centric ideology and it is not used to be applied to other ethnic or cultures. So I am wondering how you would apply something that is based off of 6 assumptions that are in Western philosophy, but not necessarily applied to the Navajo people. You also said that you do not necessarily require or value physically the person engaging, if I'm not mistaken. And if that is true, how do you determine what interventions are based? Grace is English is fair at best, and she is hesitant to speak during her evaluation. So how do you conclude what she is experiencing and what interventions are best when she has issues of communication with you guys?
All right. Now we have a 2-minute break for preparation and adjustment.
You want
Okay, are you ready? Okay, Model B, you may begin your body of your speech.
So the CMOPE is a framework model that highlights both performance and engagement in occupation. It is a popular client-centered model used by occupational therapists around the world. It mainly focuses on person, environment, and occupation. There are 4 factors that make up the person: physical, affective, cognitive, and spirituality, which all affect occupational performance and engagement in occupations. Spirituality is the core of the person. This covers individual self-esteem, motivation, and values. So with Grace, she lives in a Navajo culture which dictates her values, and her disability negatively affects her self-esteem and motivation. By addressing Grace's spirituality, this can allow an OT to build rapport and a relationship with her, and she's very motivated to return to her home despite her full recovery and is willing to partake in therapy. The physical component of the person deals with physical functioning. In relation to Grace, she is dependent for all self-care, lacks postural control due to her paralysis of her trunk muscles, and the mobility of her upper extremities causes her pain. The affective component is related to an individual's feelings, and it's not really stated in this case about how she feels other than being uncomfortable speaking during her evaluation. The cognitive component related to an individual's reasoning, decision-making, compromises, and choices. Grace's cognition is intact and she really wants to return home. It describes occupation as the bridge between the person and the environment and classifies occupations as self-care, leisure, and productivity. Those are 3 areas applicable to Grace as she enjoys gardening, painting, cooking, and tending to her farm and animals. Environment is made up of physical, social, cultural, and institutional elements. The physical element or physical environment is the natural build, the natural and build of the surroundings. So Grace's home Grace's physical environment may not be suitable for her condition, so modifications may be necessary for successful mobility. The terrain also is also rough. Cultural environment relates to ethnical, racial, ceremonial, and routine practices based on ethos and value systems in particular. So since Grace lives on the Navajo reservation, she lives within a community who shares the same ceremonial and routine practices as well as values and beliefs. This creates a strong community and support system. The majority of the population on a Navajo reservation share the same ethnic and racial backgrounds. Social environment involves social priority of the environment, patterns of relations, social groups based on common interests, values, attitudes, and beliefs. Grace's main social support is her husband and has a sister who lives nearby. Both of her daughters are going to school out of state. And it's not stated if the individual or if she's involved with any other social groups or connected to any friends. Institutional environment is societal's institutions and practices. Since she lives on a reservation, she likely doesn't have many resources available to her, like the hospital is 4 hours away.
Okay. Model A, you can start your 1 minute tough questions segment.
So this model may be used all around the world, but that does not necessarily mean that it's applicable to all cultures around the world. So my question is, you make 6 assumptions about the person. Do you adjust or change these assumptions or modify them appropriately to the culture you work within? Once again, these assumptions were made by Canadian occupational therapists with a Western social view. So what do you do to adapt to other cultures specifically? You also talk about physical is an important aspect of your model. Do you view them doing things in their environment firsthand, or are you only questioning them about how they complete these tasks? And if you only question them, how do you get around Grace's language barrier? Once again, her English is fair, and she is hesitant to talk in the evaluation. And this also relates to spirituality. How do you get around communication barriers without directly witnessing it firsthand?
Model A, you can start your 4 minute body of speech.
So the EHP model really looks at Grace's unique abilities, experiences, cognitive and psychosocial skills within her Navajo culture. And we get that first at-hand experience in looking at her natural environment. We also look at the major roles at tasks such as her mothering, community member, and wife on the Navajo reservation, since those are huge aspects of her life. The EHP really takes all of her environmental context into consideration when completing her tasks at hand. Like looking at the rough terrain and her only having water and electricity. This really, we look at it firsthand and understanding how that's going to impact her tasks being completed of that day and throughout her life. We also are assessing her environment properly, and if that's not done right away, she won't be able to complete her tasks independently in the future, and she won't feel successful as a mother, as a wife and a community member. Like how you said, she takes care of her livestock, half her livestock she does the cooking and cleaning. And then the EHP model also allows for 5 different intervention options, which helps the OT decide what would suit her case best. For example, we have establish and restore, and that's restoring Grace's functional mobility, performance, thoughts, and strengthening her tasks. We also look at alter. We are looking at altering pathways into her terrain since it is rough, and looking how to make more adaptive equipment for mobility for her to be able to get inside her home. We also are assessing adapt and modify, using adaptive equipment to help her get around her property or help her with cooking her Navajo culture foods is really important to her in her roles as a wife. And then we assess prevent, so preventing her from further injuries and really assessing her property and restoring and making sure that she's not further hurting or harming herself. And then we're also looking at creating a more adaptive or complex performance in context. So with her new disability, we really want to look at her in her own home instead of being in the hospital, because that's not realistic to where she is living. She probably doesn't have a lot of the nicer equipment at home than they do at the hospital. Lastly, the model also allows the OT to observe and evaluate Grace's performance in a client-centered and natural context where Grace feels most comfortable. Grace feels most comfortable clearly on the reservation since she has never left until having to go to the hospital. EHP would allow the OT to make intervention plans within her natural environment, so when she does get discharged, she'll feel confident and successful doing the traditional roles at hand. So we really want to focus on, our model focuses on really making sure she feels comfortable when she is discharged, because she does have all those barriers and limitations when she is home.
Okay. Model B, you can ask tough questions for 1 minute beginning now.
So how would you educate others, say Grace, her husband, or her 2 daughters, who may have a difficulty understanding the different intervention strategies? For some, adapt and modify may be confused with alter. So how would you approach that with them? And how would you word it for them to understand? In addition to that, Grace needs rehab. If this is a model that focuses on capabilities and performance ranges, how would you address restoration and rehab to allow her to go home? You stated using adaptive equipment. What if Grace does not want to change anything in her home? She's done everything by hand and does not have a lot of technology to begin with. So what if she refuses to use that adaptive equipment? Lastly, Grace appears uncomfortable when speaking during the evaluation. We already know that she has an English barrier. So how would you address this issue with her? What approaches would you take to help her?
Okay, starting now, we'll start the 8 minutes of open dialogue.
All right. Well, the CMOPE is presented with 2 other models, the Canadian Practice Specific Model, or the CPPF, or excuse me, framework, that's the F part. And then the Canadian Model of Client-Centered Enablement, or CMCE. And those 3 models come together to create the client-centered care that we see in the overarching COMPE. The Canadian Practice Framework, or the CPPF, there's a lot of acronyms here, bear with me. The framework guides practice, follows intervention from beginning to end. So it's kind of like a roadmap, if you will. It guides through the intervention process, and there's 8 key action points. Some of the main ones that pertain to Grace are setting the stage and agreeing to the objectives, because we know that she's pretty timid going into it, and just making sure we're on the same page and agreeing to the objectives and knowing what she's really getting into would be very beneficial for her. Also, establishing a collaborative relationship, again, just having that conversation or being able to collaborate, communicate, and knowing what each person is doing. It's key to giving her the confidence that she needs to get through the intervention. The CMCE has enablement foundations. There's 6 of them. There's 6 of them, and then they work through the action points, which are 8 of them, from the CPPF. The 2 key enablement foundations from the CMCE that really pertain to Grace are the choice, risk, and responsibility, as well as power sharing. She's able to make these choices, know about her risks and responsibilities from the choices that she's going to make, whether it's going back home and continuing rehab there. And then also the power sharing, just making sure that it's an equal group and making sure everyone has some skin in the game. So,
Going off of what Casey said, we clearly have intervention strategies. We have assessments that come with our tool. What kind of assessments are you going to use? Because the EHP does not have an assessment that comes with it.
So you guys, there's a lot of questions. So we were first originally asked education difficulties with the family, restoration, adaptive. So can you guys just probably just start with the education difficulties? Can you ask us that question again?
Yep. So the question was, how would you educate others, such as Grace, her husband, and her 2 daughters, who may have difficulty understanding those different intervention strategies? Because for some, adapt and modify may be confused with alter.
Okay, so one of the great things about this model is that we are interacting with them directly in their environment. We don't have to be constrained by the barriers of language. We could show by example. They could physically see us do things and incorporate them into that practice. So when it comes to educating them, they're going to see it. We're going to correct their actions on the spot. We're going to have a body language dialogue and verbal, but if there are barriers there, we could address them on the spot. And I could go through your other questions too. We could go through one more. So why don't you guys ask me or us one more, and then we'll address that question, and then we'll go ahead and ask you guys a question.
I know earlier you mentioned that we don't have a rehabilitation piece, but we do have restore, which is within our thing is restoring a skill or ability that the individual lost. So that is rehabilitation, but we're just using in a different term. So we are still rehabilitating Grace in her mobility, but we're just restoring it we're saying restore instead of rehabilitation.
And at the end of the day, you know, we could get caught up with words and semantics, but the truth is we're going to see them and be there in person. And as an OT, it is our job to effectively communicate. We're not going to use terms or jargon, right? We're going to speak in plain language for them to understand what we are communicating. One question I do have for you guys really quick is that we have a lot of points and a lot of terms, and we're kind of getting past that. When you have these communications with your clients, is it done in your office? Is this done face-to-face, or are you physically going out to your environment? Because I have not heard any mention of you guys actually participating in the environment.
So I'd probably say for like this scenario that this is outpatient and they are coming in. She does live 4 hours away, so that's where you would have, you know, we're at a hospital 4 hours away. Or
so how do you get past communication
reservation doesn't have a lot of resources. So that's why we'd probably be in the office. As far as language, it says that her husband and her daughter are present. Sometimes that, you know, has an issue with getting the client's perspective off correctly, but I think they would know each other well. As also being so close to a reservation, you would see probably a translator or somebody, hopefully an occupational therapist that is culturally informed for a reservation that is neighboring. So you probably see a lot of clientele from there that hopefully you are culturally informed therapists, so you're able to communicate and, I mean, understand their culture. And that's, I guess, when you talked about how it would be addressed across cultures, I feel like that would be one way. The Canadian model is able to adapt other frameworks because it's so flexible. So if these components aren't, or assessment tool isn't necessarily the right one, you can adapt it to other ones as well.
So where I'm a little confused is you asked us if we have, what are we going to do to get past education difficulties with the family? And, you know, I'm telling you, we're going to be there to show them. Yet when you guys talk about it in your office, now you can explain these things clearly. And we've learned things about cultural humility where we don't truly know their culture. So once again, we're looking at and hearing about assumptions and treatment that's 4 hours away, hands off. And like you said, how are you going to educate them? The same question you asked us about educating and the difficulties with their family, how are you going to address that without physically being able to show them and you could only rely on your communication?
I think the great part about our model is that we take into consideration their wants and needs and all of that. So that's where we are getting, you know, we're not making all of the decisions for them. They're letting us know what they want to do, what they, you know, she wants to return home. She will return home whether she is fully restored or not.
There's also an enablement element foundation that talks about justice so that we are not putting our bias on them, so that we learn about what they need. And it's built right into our model. Okay, so that stops. Okay, now we have a 2-minute break for closing. So, break. When I switch, I'm going to give you the timer for me to do the closing statement. Okay. Model A, you may begin your closing statement.
Okay, so we have just looked at Grace, the 52-year-old Native American woman who received the unfortunate diagnosis of Guillain-Barré syndrome. We have just described how the EHP model directly applies to her and her life. We have looked into her life with no assumptions. Knowledge of the core constructs of this model are of utmost importance. This model assesses clients in their natural environment and observes their occupational performance firsthand. The person is the main part of occupation. So what is occupational therapy without the person? What is the person without meaningful tasks? What is the context in which the person does their tasks? And finally, how does the person perform those tasks in that context? And that is why the EHP model must not be overlooked in order to improve the lives of people just like Grace.
Awesome.
Okay, you can begin.
To begin, this case study is set in outpatient, so I don't know where you guys are getting the resources to travel 4 hours. Anyways, the fact of the matter is that the Canadian model of occupational performance engagement is a better fit for Grace than the EHP because our model focuses on giving Grace back her power. Based on the information we have about her, Grace seems like a woman of dignity and faith, and you can see that she relied heavily on her functioning to perform the majority of her daily occupations. The CMOPE can cater to that and encourage and coach her into regaining her functioning again. Therapists can use this model to find out what she wants out of therapy and shape the intervention around that. The AHP model cannot because it doesn't go in depth to address the therapy process. And it isn't very well suited for rehabilitation because it doesn't deeply talk about personal motivation. It can talk about tasks until they're blue in the face, but if she can't move her limbs, she can't do it the way the CMOPE does. Our model also has the CMCE and the CPPF to guide practice, whereas the EHP does not. In the end, we're talking about context versus process. We can talk about context until we're blue in the face, but what it comes down to is the sole fact that the therapy process is how we're going to get Grace back on her feet again and doing what she wants to do. The end.
All right.
Wow. Can you stop recording?
Are we still recording?